Welcome to the webinar Implant Therapy for the Edentulous Patient, a review of the latest workflow and treatment options. The lecture will be presented by Jimmy Stegall, CDT, and we will begin shortly. And with that, it is my distinct honor to introduce Jimmy Stegall, CDT, a dental industry operational management and technical guru with 4 decades of experience. Jimmy Stegall is also a clinical educator, trainer, and published author. His impressive career includes 35 years growing and leading a major dental lab in the Southeast. And in the past 7 years, he presented more than 460 educational and training events on implant and prosthetic restorations. Recently, the National Association of Dental Laboratories recognized Jimmy as their 2024 Excellence in Education Award winner, and his expertise as a thought leader, educator, and mentor has helped to advance cutting-edge digital techniques in dental practices and laboratories across North America. Thank you so much for being here this evening. And now may I say, take it away, Jimmy.
Thank you, Jessica. Guys, if you ever want to feel really good about yourself, get Jessica to do your introduction because she's pretty awesome at this. And NDX is done. This is, I think, the 4th webinar I've done with NDX in the last year. And these guys know how to do it. So congratulations to them, and appreciate you guys having me again. So I love this topic. As we know that the largest or the fastest growing part of our world right now is implant dentistry and the restorations that go along with it. So that and dentures, and it just happens to be 2 of the things I love talking about the most. And this is going to be kind of an overview and review of where we are and some of the popular workflows out there. It won't be a really deep dive and step by step, because it's pretty tough to do that in 1 hour, but I want you to leave with saying, okay, what are my options? So we'll start with just a quick overview about, when we look at an edentulous patient and, where the treatment trends going. And obviously intraoral scanners have played a big part in our world, and we're seeing more and more utilization of intraoral scanners with traditional prosthesis. So we see digital dentures, and while I'm not sure where, even though these scans look great and they're amazing, I think they're the most difficult, challenging scan to accomplish. So what my training to dentist is that, look, we're going to do some sort of wash impression and scan that. And that's still the major trend. But there are some folks that can accomplish this scan with whatever scanner out there. But this is by far the most widely taught workflow, is where you do a wash impression in the patient's old denture or in a base plate bite rim, and you scan that with the wand, because the wands do that really easily and really quickly. In our implant topic, this has got to be, if not the leading, one of the leading areas that we've seen a lot of growth and conversation in. And, we have all this technology with various systems where you can buy this super sophisticated camera and the scan posts that go with it. And you can put these posts in, capture with this camera, and that data can be transferred over to our design software or our planning software. And the result is a super accurate transfer of data. So this is just a method that allows us to really capture position and placement well, so that we can reduce the delivery time or the conversion time, because the data is so accurate that when we make something with this data added to our design, then we have good success. So it's a lot of engineering, it's a lot of technology in this. And, the flip side of that coin is that it's typically relatively expensive. We have seen some movement in that area to maybe reduce that cost and combine it to take this technology and not require a special camera, but allow you to use an intraoral scanner. I think Shining 3D might have been one of the first ones to do this, but we're seeing some of these now where we have maybe these horizontal scan bodies, and you can use different technologies to capture the data. We're still early in this field, guys, so time will tell with the research. But overall, I think anytime you do something like this, you get, more accurate data. True Abutment came out with theirs as well. Again, just a different version, same concept. Let's create something that we can scan with an intraoral wand that will give us pretty good positioning data. And, it's going horizontally so it can capture it easily. And from what I see so far, it's working really good. And it's just a great time to be in this field now and to have all these options in front of us so we'd be able to say, hey, I want to do this all on X case and I want to get the best data I can get. What are my options? And so digital dentures certainly are trending probably faster than anything we've seen in a long time because they do solve a problem in the workflow. At the end of the day, it's a denture, and the materials are great today. The strength, the aesthetics, we have everything. It's just a more efficient workflow, both in the lab and in the operatory. So, on general lab, a technician can make a denture traditionally in hour and 45 minutes, 2 hours, hands-on time. In a digital world, it's almost half of that, right? Simply because of the tools just make it more efficient. It's, that's a good thing for lab technicians. In the clinical side of things, and I tell lab guys this all the time. They say, how do I get my dentist to want to do a digital denture? I said, well, quit talking about it being a digital denture and talk about it being a 3 appointment denture because that's what it really does for us. The workflows allow us to drastically reduce the amount of time we spend chairside with our denture patients. So big trend, very successful, and working great. NDX, by the way, was one of the very first labs I trained in this workflow, and they've been doing it all along. They do really well because it is a proven workflow now. The system that National Dentex uses has well over 1 million arches now. So it's not new anymore. We're not testing anymore. And, the biggest win that we have with a digital fabricated denture is that we eliminate all the discrepancies associated with a traditional analog workflow. And so we had a better fit. That's the bottom line, is a digital denture fits better. So when I work with dentists and staff and we talk about scanning, again, we talk about scanning wash impressions, and we typically use a 2-step wash impression, heavy bodied around the border, go in the mouth and do border molding movements to capture those borders well, and then a wash and go back in and capture them again. And then scanning is easy, and I use all the scanners. I've not had a scanner I can't do this with, so I got no real preference. That most of current technology works really well. So that's the major trends. But let's dig into the implant for this patient. And you look at this patient and you say, if you're a dentist and you got this patient, or you're a lab guy like me doing a consult, and you look, what can we do here? The first thing I think, as an old school lab guy, is that there's pretty good ridges. We could make some traditional dentures here, and they would probably be pretty good. But the patient might have come in and said, hey, I saw a TV commercial about getting teeth in a day, these implant things. Can you tell me about them? And so we can start having those conversations and, explain to them the options. And it can be a traditional denture, and this is what it takes. This is the treatment time. This is the cost. Or it could be a simple overdenture. Again, treatment time, cost, what's involved. Or we could go to the other end of the spectrum and do a fully blown fixed, and all on X, where we're going to put 4 to 6 implants in. We're going to bolt a restoration, and it'll be like as close as we can get to having real teeth again, and all the things associated with that. And then there's a new one. Well, it's not new. It's been around a long time, but it's not widely known. It's not widely talked about. But I call it fixed/removable, and it's basically a fixed, fully implant-supported restoration that the patient can remove. And we'll talk about all of these. So when you look at the spectrum of implant-supported edentulous restorations, you got to start with these because this is still by far the most common, the most widely used, most restorations to date for an edentulous implant patient. And that is what we affectionately call the desk lock or the locator, right? The 2 lower cuspid bicuspids, 2 implants, 2 abutments, 2 clips in the dentures, right? And sometimes they're connected with a bar. Sometimes the attachment's on top of the bar. Sometimes it's a simple trailer hitch. Sometimes it's a clip. But all of these are what we classify as a removable full arch implant device. And that is saying it is a tissue-borne appliance, but is yet implant retained, implant supported. So implant retained, implant supported but yet tissue borne, meaning that the denture will move. And in various ones of these overdenture attachments, it'll move more or less, but it will move. And so that's not bad. That's just what it is. And again, the most common edentulous implant restoration out there is that two locator overdenture. Very economical, very minimal space required, and very successful. So that's why it's the most common. It does work. I think there are specific patients and treatment plans that call for this, and it will always have a place. Now, the other end of the spectrum is, the all on four, or what we now affectionately call the all on X, because all on three doesn't work. So we see more and more surgeons or implant placers putting, 5 or 6 implants in. But in essence, they're all the same. We're going to put some implants in the bone. We are likely to put some sort of angle correction top. We call them multi-unit abutments on top of that, and then we'll bolt some type of appliance to that. And that appliance could be as varied as acrylic wrapped around a bar. It could be a solid piece of zirconia. It could be zirconia supported by a metal framework. That we have choices today, and it's good to have those choices. But at the end of the day, whereas the locator is tissue-borne implant supported, this is the appliance. It's fully implant-borne, implant supported. The restoration rides completely on the implants. And this is why, it will feel to patients more like having real teeth again. But it's also the most expensive and the most surgery and healing and everything else. So, you make your choices. The third one would be the fixed removable, which it is fully implant supported, implant borne, but yet the appliance is removable. And there are some needs for this as well. And we'll talk about those. But it's nice having the 3 option. This one, I labeled my what else you got, because that was the question I would often get, right? If I was on a consult, you know, the lady would come in and she'd say, look, I'm tired of wearing dentures. I want teeth again. And so obviously that leads us directly into the all on X conversation. And you explain that and they say, what else you got? We would say, well, we've got this thing here where we can put 2 in and we can, but it's still a denture you take out. Well, what else you got? And for the longest time, we didn't really have anything else. And then, this product came along and it gave us the what else you got, right? It is a right halfway between as far as cost and involvement and surgery and everything else, and a cost to the patient. So it became a pretty good third option for certain situations. And we'll talk about that. So when you're starting, right, you've got to, okay, where do we start? And I always felt like it was best to start with the patient and trying to find out where they've been. Like the lady who saw the commercial and said, I'm tired of taking teeth out at night. I'd like to have teeth again. So that leads us into that all on next conversation. And in today's world, that conversation is successful a lot, and people proceed with that kind of treatment. But we want to know, what it is. Imagine this one though. If it's a 80-year-old grandmother, and she says, I really don't mind my denture. I just wish it was a little more stable. I wish it stayed in better, didn't move around as much. And she's 80 and all she really wants is stability. I mean, that's a locator conversation, right? That's a desk lock conversation. That's just 2 implants and 2 abutments. We could even retrofit our existing denture to do that. So, choices, right? But I need to understand from the patient, what their needs and desires are. And when you have that conversation, the things like cost, but it's always the first or second question, right? How much is it, and does my insurance pay for it? And so you got to have that conversation, and that's a pretty easy conversation to have, because it's just, again, offering the patient options, right? This is treatment 1. This is how much it costs. This is how long it takes. This is what's involved for you. And this is treatment 2, or this is treatment 3. And you can kind of help make those choices. But as the clinician and the labs, we have to figure out, okay, well, wait a minute now. They may want this, but do we have the ability to put the implants where we need to put them to do what we want to do, what they want to do? So that's also in the conversation. And can we get the number of implants that we need to do that? So they aren't always just, hey, what do you want? Okay, we'll do that. So this lady is a great story. All on X turned out great. Bite was good, restoration's good, implants solid, but she comes in not too many months after final delivery and is unhappy. And it's not to do with the functionality or the aesthetics of the restoration. Well, not completely the aesthetics. Her problem was that when she smiled really big, or when she laughed, in a group setting, having fun, her upper lip would get stuck between her gums and the restoration, and she'd have to reach up real quick and pull it back. And she was not happy about that, and I really don't blame her. And I can remember as a lab guy thinking, "Oh, that's easy. I'll just put some more stuff up there, right? And we'll stop that." And immediately when you say it, you're right, no, I can't do that because if we add more stuff up there, she won't be able to clean it, which is also a very big requirement here that we got to keep it clean under there. So it was a challenge, right? And it was a simple thing of, what do we got to do? And so this was a case that really needed more of a flange. But we can't do that with a fixed restoration, right? So we were, back at a locator, or by that time we had the Conus product, which is a fixed removable product. So all about options to me, and patients will let you know clearly, if they're looking for something fixed, I want teeth again, or no, I just want my denture to be still. So that's easy. But then we've got to think about the patient's dexterity and their ability to maintain it, right? And of course, costs for them is going to be up near the top. And then intraoral limitations. Do I have room? Can I put them where I need to put them? That kind of thing. So dexterity can be both things, right? Does the patient have the ability to get a overdenture snapped in and out efficiently, right? Is it just too much? Age, arthritis, whatever. Maintenance. If they have the ability to do things, but are they going to maintain it, or do they have the ability to maintain it? Right. I was very naive in the beginning of my career with implants, thinking that surely patients going to keep them clean, and we learned pretty quickly that no, they don't always get where they are because of good hygiene and good care. So we have to think about these options. And then as lab guys, we immediately think about, functionality and how we can do things the way we need to do in the lab. And one of the conversations you always have initially with anything fixed or fixed removable, anything that's totally implant supported or born, I'm sorry, implant born, we think about AP spread. And this relates directly to how far back in the mouth we can go. I can remember early in my career, just getting a case, and here's the case, 4 implants are already placed, and we need a, full arch restoration all the way back to second molar. And you start measuring the AP spread and you realize you can't. There is some very specific engineering principles, and the main one is called AP spread, where we draw a line between the 2 anterior implants and the 2 posterior implants. We measure the distance between those lines. We multiply that number by 1.5, and that number tells us how far distally we can go with our restoration. And I can tell you a lot of times we can get to a first molar, maybe. Um, it's tough. If you don't have your posterior implants distally enough, it's tough to get teeth too far back in the mouth. So we want to plan for that ahead of time. Obviously, we want to have this conversation before the implants are placed. And if we know we want second molar occlusion, then we have to plan for this AP spread and get our implants placed accordingly. A bigger problem we have, I think, is the most common in the lab, and that is vertical space. When we decide on the type of restorative workflow we're going with, we've got to determine, do we have or can we obtain the amount of vertical space we need to do this? And it is a challenge in labs. It's something that we deal with pretty routinely, that we don't have the space, and we're always pushing the limits, and we end up with fractures or breaking. And so my rule of thumb was I measure from the ridge that we're restoring to the occlusal plane that we're achieving. And whether that's the opposing teeth or whether that's going to be the occlusal plane when we're done. And, the goal and target, I think everybody would be happy with, is if we could have 15 millimeters. If we could have 15 millimeters from the surface of the ridge to the occlusal plane, and you look at the list of things that we could do, a bar, a hybrid, a conus, a desk lock, a locator, a crown and bridge case, which of those things do you think we could fit in that vertical space? And it's a trick question. Of course, they all will fit in there. That's the kind of our dream, is at 15 millimeters. That's not the norm. The norm would be, I think, 12 millimeters is pretty much what we see for the most part. And 12 millimeters, you can't get a bar and a hybrid in there. So we're limited, and we start running, and even in the conus would have problems at 12. Even though that's their limit, I think that, I'd rather have 13 to feel comfortable. So again, planning, right? Not only do we want to make sure the implants are placed properly in the right position to do what we want to do, but we want to look at this vertical space so that, while we're in there placing implants, maybe we do some bone reduction if necessary to give us that vertical space, because anything less than 12 millimeters, we run into challenges. And in reality, at 9 to 11 or less than 9, you might can get a locator and you might can get some crown and bridge in there. Otherwise, it's going to be challenging. We're going to have stuff breaking. So vertical space is a very big consideration. So let's look at the options one at a time, right? And we'll start with the basic attachments, the overdentures. And again, this is the OG. This is a guy that's been around. Locators, the shortest vertical height, the most options for retention, metal housing that holds a retentive element. Very durable. It is a Delrin, so it is something that wears and we have to replace it. So there is a little bit of maintenance with locators. Ideally, we've got two in the cuspid or bicuspid and in lowers. When you add more than two, you increase the chance for problems. When you try to do them on the maxillary, the problems increase as well. So I think the best case use for these type of implant attachments would be, a lower denture, cuspid bicuspid position of a couple of implants. And I can take an existing denture and retrofit, and we just have to order the right abutment to fit our implant. So very good, very successful, been around a long time. They've changed and modified and made it better as they've gone. We got scan caps now. All those things help us as we move forward. And they do have a fixed version now. This is the locator answer to All on X. And it's basically a different retentive element that the patient can't get off. It's super retentive. But it is still a type of nylon, so it still gives a little bit, which, the theory is that might be beneficial. Um, I'm not hearing a lot about it, but I do know that it's being done somewhat. I think it's a little bit of a challenge in some cases, but they do have that option now. Desk-Lock was something that I had never heard of until I started working with Des. And Desk-Lock is just a locator clone. That's all it is. It works and is exactly like a locator. The parts are interchangeable. It's 100% mimic of locator. Now, some of the tools I think are actually a little better. Of course, we use them all, but their torque wrench tip I love the most because it grabs the abutment really well. But all the colored caps, retentive elements are exactly the same. You could use them on a locator and vice versa. And so it's just a good option out there. Just having options is great. I do like the little hand tool better than the other one. But as you can see, it does exactly the same as the locator tool. So just another option for us using a locator type restoration. Desk-Lock, and you can see 100% compatible, but it is less expensive. And so, as we started working on a locator Desk-Lock workflow digital and resulted in this, and this works really well. And we'll talk about this again with CONUS, but if a patient has an existing denture, and we're going to add a couple of implants and a couple of locator Desk-Lock abutments, this would be the workflow to try to do it digitally in just a couple of appointments. And we're going to take a wash impression, showing where the implants are. So typically the healing screws or cover screws are there. Take that wash impression and leaving the denture in, we're going to scan the bite. Then we're going to take the denture out. We're going to scan the wash impression and the buccal surface of the dentures. And then we're going to put a scan post in, and we're going to scan with scan post. Then we'll take the scan post out and put cover screws in. Send all that data to the lab, and the lab's going to fabricate. They're going to, you'll need to do a measurement, right? How deep the tissue is. So surface of tissue down to the top of the implant, and that tells us how tall of an abutment to order. And with that information, we can order the abutments, we can fabricate the denture, and then send the denture with the caps and the housing and the abutments. And the patient comes in, second appointment. We're taking the cover screws out. We're putting the locator Desk-Locks in. We're snapping on the retentive element, and we're picking that up chairside with one of the chairside pickup materials. And we're done. And we just did a locator Desk-Lock denture in 2 appointments using digital technology. It works really well. So let's go to the other end of the spectrum briefly and talk about fixed hybrids. And again, this is just a restoration that's bolted down to 4 to 6 implants. And again, it could be bolted directly to the implants. It could be bolted directly to a element that is bolted into the implants. We call it multi-unit abutments. It could be solid zirconia. It could have zirconia with metal sleeves. It could be a bar wrapped with denture acrylic and denture teeth. It could be zirconia with a bar. I mean, we really have plenty of options, and we just have to pick what we think is appropriate for the patient or for our workflow. And it's nice having all these options and solutions. And again, moving into the digital realm just makes all this easier. But all of them work the same, 4 to 6 implants. And in the beginning, we're putting 2 implants in the front, 2 in the back at an angle. We're correcting that angle with, again, an MUA, and then we're bolting the restoration to these abutments. And that's pretty much how they all work. And it doesn't matter what system you have. I think they're all very successful. There's some that I've had good success with and others that have been a challenge. I mean, the challenge for the dentist is, getting this stuff screwed in the back. So ones that have easier, better delivery systems, we've seen some of these angled abutments break because if you think about it, that abutment in the posterior has to be able to receive that screw that holds it in and then receive the screw that holds the appliance on. So, you have to build the abutment around those screw channels. And so that makes them either, not solid, half hollow, or whatever you want to call it. And so we've seen some fracture of those abutments because they're not robust enough. But others like this is one where it is a solid piece because it's actually 2 pieces, right? You screw in the bottom half and then you torque in the top half, and it's all solid so that you don't have to have the big access hole for the screw. And that's a more robust, more successful system. But whatever system you're using, the sequence is the same, right? We're going to put these things in. We're going to, if we're going to immediate load them, then we're going to put the MUAs on, and we're going to have our temporary restoration pretty much done through planning. Place the implants, put the temporary on, let everybody heal, and then good to go. And in the beginning, right, all of these were done with acrylic, with a bar or some sort of metal strengthener. And in the beginning, we just I assumed that patients would keep them clean. So we tried to make them look as close to natural as we could, which meant flanges and scalloping and festooning, and quickly understood that no, that doesn't work because, if you have any kind of flange at all, they can't, they're either not going to get the water pickup in there or not going to get the superfloss up in there, and it's going to create problems for everybody. So we learned pretty quickly that the underside of these restorations needs to be as convex as we can make them or as flat as we can make them, which, makes it an aesthetic challenge at times and, makes it a problem if we do have to hide something. So that was a drawback and still is. And then we moved into more of a zirconia restoration, and this is still the most common all-on-X restoration, and that is a solid zirconia piece. But that's problematic as well. That's a big chunk of zirconia, and zirconia, if you don't know, is milled in a green state and centered in a very long cycle at very high temps, but very specific ramping up of those temps and ramping down of those temps because it has to heat up and cool down at a certain rate, or it generates cracks and it warps, and it's a challenge. And so I can remember many times, designing one of these things, in 3 hours, milling it in 3 hours, and putting it in the centering furnace and going home, and not sleeping that night, hoping that when I got in the next morning that it was going to fit the model. And sometimes it didn't. It had a rock in it, and at that point, it's start over. It's mill it again and center it again. And so it can be a challenge. And so technicians that do this really well, they had my admiration. It's an awesome skill to have. It's a very difficult thing. I had a dentist call one time, and it fit the model well, but he said when I put it in the mouth, he said it is not rocking, I would call it, but a very slight movement. I can see a little bit, tiny bit of movement. Can I just go ahead and tighten it down? Do these things have any give at all? I said, Doc, that thing will bend one time, and you'll know it. You'll hear that sound we all hate to hear. It's a tink sound when these zirconias break. So things have been done in the past, right? And some people are doing this still today, where we kind of change the design of how we do this. Instead of a solid piece, we take away some of the bulk and make it as a prep form or a thimble type thing. Some call it a thimble prep, where the bar or the main framework looks like tooth preps. And then we make crowns or bridges to cement on top of that with the goal or hope that we're reducing an overall bulk of the big part of the bar. And that if anything does break, hopefully it'll be one of the crowns or bridges, and we can leave the main framework in the mouth and just replace, the outer crown. And that's a reasonable solution, and it has worked well. But you still have to deal with the fact that it's a big piece of zirconia, that it doesn't bend at all, that it's heavy, and that some patients don't like the sound or the feel against natural teeth. See a rise in these high strength polymers. You actually can mill that spindle or that thimble prep type of framework out of these high strength polymers. Very tough. It's one of the hardest things to mill in a milling machine. Takes a long time. Very expensive product, but it's about maybe a third of the weight of zirconia and is strong enough to be a permanent long-term full arch restoration. I like this solution. And having this spindle framework out of the high strength polymer and then making the crowns or bridges however we want to do it, and then figuring out how to make the pink tissue look. And there's plenty of products out there on the market for that, whether it be porcelain or composite. And I think that's a good alternative. The one on the bottom right is actually a full solid titanium thimble framework with pink porcelain and three zirconia bridges. And that was made for a patient who kept breaking everything we were putting in the mouth. And we thought, well, we'll just make everything out of titanium and see how it holds up. And, it worked okay. So those are our options for overdentures and all on X fixed, right? And then let's talk about this fixed removable thing, and it's called Conus. Comes from the Atlantis company, and it is that what else you've got. It is a fully implant supported appliance, right? Just like an all on X. The only difference is it's not permanently fixed to the implant or the abutments. It's a removable restoration, but it is fully implant borne. It doesn't have any movement to it. So it's a telescopic friction fit attachment, a custom titanium abutment with a stock gold alloy retentive element up in the denture. First time I saw this, I thought, wait a minute, titanium, very hard, very lightweight, gold, soft. That's not going to work, right? The gold will wear out pretty quickly and it'll be loose. And actually, the engineering has taken care of that from the beginning. And because of this thing they call the conometric concept, this thing actually gets more retentive with age. And it's just the way the friction works. It's a fully customized abutment, which it has to be because for this thing to work best, all the abutments have to be parallel. You have to have 4 abutments. I've seen it done with 6. I don't know that it necessarily needs 6, but you could put 4 or 5 in here and that's okay. They make this for any major implants, fully FDA compliant and works really well. It came from this product. This was the founding product for Conus, and it was called Syncone. Been around a long time. It was an ankylose system product, and it was a stock abutment with that gold cap. But there's only 2 options. It was one straight and one angled. And remember, they have to be parallel. So that meant implant placement was critical. If the implant aren't placed exactly right for these 2 options I had, then we really couldn't do this. So we did some of these, but not many, because again, implant placement can be tough, especially in the posterior, to get that angle exactly that we needed. And if they're not perfectly parallel, we ran into problems. But it was a genius concept, and when it worked great. And I remember doing one with one surgeon, and he fell so in love with it that we started doing them more and more, and we were fairly successful. But we realized pretty quickly the challenges of, man, if the implants aren't placed exactly right, then we're going to have a problem. So what happened was Dentsply Atlantis, bought Ankylose, and Ankylose engineers and the Atlantis engineers got together and said, hey, we can make this product better. And what they did was they used all their technology and know-how and FDA clearance, right, and all that stuff that they had already been doing for a long time with Atlantis single tooth custom abutments, crown and bridge abutments, and said, hey, let's blend it over with this Syncone concept and make a custom Syncone abutment, right? And that's what they did. right? That's all this is. This is just a custom Syncone abutment. Still uses the same exact gold cap that we always did before with the Ankylose product, but now the abutment can be fully customized, and that's customized from the implant interface all the way up. So emergence profile, margin placement, everything is customized. What's blended exactly is the internal fit of the cap to that abutment, that same 5-degree taper. And so the customized Syncone product became known as Conus. They just gave it a new name. And I think they messed up. They should have called it customized Syncone so we'd know, but Conus is the name of it. So now with Conus, we have the ability to make those abutments parallel through the use of digital technology. It's easy to do it now, right? Because the computer can tell us exactly, what the angle they need to be at to be fully parallel, no matter what the implant placement is. I think we can correct up to 20 some odd degrees. So pretty successful with this. Um, it is a little bigger cap than a locator cap, so you got to have the space for it. But again, 12 to 15 millimeters is ideal. And they're very retentive, obviously, to the acrylic. You see all the knurling, and the retention is off the charts, right? This really requires education and delivery with the patient of practice getting it in and out because the retention is pretty good. And as I said earlier, with age, right? Because you've got four of these things, and my analogy is you got four beer glasses that are linked together, and if you've got moisture between them, how hard are they to pull apart? And they're very hard to pull apart. So it's a frictional fit, and as the taper, flares out, the further down you go, the more retentive it becomes. The retention is actually only on maybe a couple of millimeters of height of the abutment, not the full length of the abutment. So again, the harder you push down or the longer the patient wears this thing, the more retentive it gets. So this is an appliance we tell the patient, look, you have to take this thing out every day or every couple of days, because if you don't, if you put this in and it's gonna be comfortable. It's the chewing power, right? It's retentive, it's great. And if they wear it for a week or two, they're going to really struggle getting it out. They'll be back in the dental office saying, hey, I can't get it out anymore. And that's because of this retention getting better with time. And it is really, really good retention. We just have to coach everybody up to understand how it works. And so there's that, what I call the magic millimeter. That's basically where all the retention happens. Everything else is not, it's very light retention, but most of the business happens in that magic millimeter. So in order for that magic millimeter retentive element to work properly, you have to have the space for it, right? So you notice the space between that millimeter and the acrylic. If you don't have that space by, a mistake in the pickup, then it can't swedge out. So you're not going to have it. And one of the calls I would get is that, look, there's just hardly any retention at all, and you flip it over and you look, well, the pickup, leaked around the gasket or whatever, and you've closed the magic millimeter space. And so it's got no room to swedge. So we just take a 557, go around the outer edge of the cap and open up that freeway space, and boom, you got solid retention again. One of the cool things about this fixed removable type of appliance is that you can have a flange if you want to have a flange. Or if you notice on the previous picture in the upper right, I can make it look like any other all-on-X appliance if we want to. But if we are doing this, a lot of times we're doing it because we need a flange, either to help the lady hold her upper lip in the right spot, to cover up some bone loss, or lip support, cheek support for aesthetics, whatever. If you need a flange, you need a flange, right? And the nice thing with Conus is we can have the flange because, again, the patient's going to take it out every night to clean it. But if we get in there and realize, you know what, I don't need the flange, we just cut it back. And so it's a great alternative of using the benefits of fixed, right? Totally implant support, totally implant borne, right? It feels like teeth again. And removable, I can take it out and clean it. And so it's a wonderful blend between the two. And so that's why we call it the hybrid. So we get the benefits of both restorations. Now, people say, you really like that? I said, well, I did 10 to 12 a month. I really did like it. But, you got to have your workflow down. You got to make sure your spacing is right. And at the end of all that, it's still not the end all. It's just that what else you got, or it's just that option that we have. And in the cost world, a locator, a desk lock, restoration from a lab would be, I don't, today's rates are all different, but let's just say it's $1,000. And a all-on-X appliance, let's say it's $3,000. And A conus would be 2,000. It worked out that way every time. So you've got your top tier restoration at top tier price. You've got your basic restoration at bottom restoration price, and then you have this third option which falls right in the middle. So that means the price to the patient can also be in those same tiers. So a lot of times patients would ask the all on X question, and you'd give them that information, and they'd say, "Ooh, 40 grand, 30 grand, whatever it was, what else you got, right?" And you give them the locator, well, that's a denture, what else you got? And you give them this, and this would be, 15, 20, whatever, half the price of the fix. So it's great to have the options. So it traditionally is how we started, right? No digital, right? Other than getting the abutments made. And we could do it for the most part in 4 appointments. Right. And the first appointment, right, is typical. Let's take some records, right? The impressions are taken with the implant impression post. We're going to get a bite, all those things that we do, to move forward. Now, if I want to go digital, I can go digital today. That's the nice thing about appointment one. Now we have scan post. Now we could do impression wash and scan impression wash. Now we can start gathering our data. We can get our bite digitally. All that can be done digitally. So that data, whether it's analog or digital, goes to the lab, and the lab's going to do a setup, right? And traditional setup is teeth and wax over that model, or it's a digital setup, right? Same concept, different tool. And so the wax try-in analog is as always. I would always like to put a couple of cylinders in the wax try-ins to help the dentist hold the try-in well. Let's check everything. Because all this is about is making sure we have the teeth in the right spot, right? The bite, the tooth position, smile, everything. On the digital workflow, maybe we print it in a monolithic, we put some cylinders in it. Same concept, right? We're going to put these in the mouth. We're going to check to see if the teeth are in the right spot. Either way, different tool. So the second appointment, you got your wax try-in. We're going to put them in. We're going to make sure the patient's happy. We're going to make sure the bite's right. All those things that we do in a try-in appointment. If it's digital, it's the same concept, just different tool. I'm not having to have the dentist move teeth in wax. I'm saying, look, if the bite's wrong, just tap, tap, grind, grind, and take a new bite registration. It's that simple. Third appointment, or the lab's next step is, okay, we're going to take this data, whether it's analog or digital, and we're going to order the abutment. So now we know that the patient's happy with the tooth setup. Now we know where we can put the abutments. So now we can order the custom abutments, get the angle correction done, get the abutments in the lab. And in the traditional analog acrylic work, we almost always put a metal strengthener in these. And so we would, the first step would be to take that data and make a metal strengthener. And we typically waxed and cast this. Now, the guys at NDX have done some marvelous work finding other ways to make these strengtheners. I might show you a picture of Tremaine shared with me at one time here in a second. But bottom line is we want to strengthen the restoration, and we would cast this, and this would go back to the dental office, right? And so in the dental office, we're going to take this strengthener, whatever it looks like, right? And this is some of what Tremaine's work had done, and where he designed these strengtheners digitally and then he milled them out of one of the high strength polymers. But they're going to go back to the dental office, and we're going to put the abutments in, and we're going to put the caps on the abutments, and we're going to pick up those caps in the strengthener with crown and bridge cement. And just make sure everything's aligned, and pick up the caps so that we can come back and then put the denture around it. If the tissue had changed a lot between appointments, then we just pick up that metal framework in the impression. So we have that new tissue data. So that goes back to the lab. And if the tissues change, so we have a new impression, then we just make an index and we jump fit it over to the new model. If it's good, then we just use the same model and we start processing the analog denture. If it's digital, right, it's pretty simple. We just pull the data in, make any necessary changes with the bite based on the data we got, and then we just print or mail the denture. And we're ready for delivery. So the fourth appointment, I always preferred that my dentist pick up the caps chairside. We would go out and assist. And the good thing is that there are materials out there. You can use cold cure acrylic, but there are easier to use materials like Quick Up or Easy Pickup or Chairside from different manufacturers that all work with traditional acrylic, with the printed dentures, with the milled dentures really well. And they just make these pickups pretty simple. But the one thing with these conus is that you have to make sure that when you're picking these up, that you're not invading that magic miller. You can see the whole millimeter, sticking out inside that denture, so certainly not invading it there. but it is a common problem because it's a little bit difficult to do in the mouth sometimes. But there's a little sleeve I'll show you in a second to make it work. So just another review of the workflow, the 4 appointments, and how everything goes between the office and the lab. There were times where a dentist would say, "Hey, this is a little old lady. The bite's not tight. She's wearing a denture opposing. Can we not do a framework?" And yeah, we can. And that takes out an appointment. We can do it in 3 because we're not making that framework. Again, I like the framework, but when we get to delivery in the mouth, these are the seating sleeves. They're little, you know, rubber gaskets that you fit over the caps after you engage them on the abutments, and they're designed to, not only protect the tissues, but also to prevent the acrylic from getting into the magic millimeter space. And the picture you see on the right are showing improper application of these gaskets. They're pushed too far down. And so the magic millimeter is exposed, and if we pick up, as you see there, then there'll be acrylic where it shouldn't be. So we want to make sure that that skirt is not placed beyond the magic millimeter. It tucks right up under that bottom knurl, and it's got a little, uprise on that skirt for that purpose. And you just want to make sure it's on. I like to put the skirt on the cap before we engage the cap in the mouth. That way I know where it is. We avoid pushing it down after that. But that would be the problem, right? If you get that too far down. But once it's there, it protects it, and we can go about the pickup. And you can see how, in the bottom middle picture, how it protects the acrylic or the pickup material from getting there. And when we're done, we just peel out the white gasket, and we're ready to go. So again, I like all these materials, the Voco Up, the Quick Up, Voco Quick Up, the chair side from Zasco, the Stern Gold Easy Pickup. They all work great. And we're done. And so this was the lady who we converted from an All-on-X to a Conus because, she needed a flange. That was that simple. Some struggle with the retention. So, we do some things like, fingernail notches to help them, get a handhold. Some labs I've seen make little tools to help the patient, anything that we can do to help. One of the things that I like to do was to always make a sleep denture. And so it's just a scanned copy of the final denture, and we cut it way down, and we don't even put anything in the holes. And when we deliver it, we say, "This is your sleep denture." And the whole thing is, look, you mean I sleep with that? Yes, which means you take the other one out because I need you to take that out every day, right? And clean it, number one, but number two, so that it doesn't get, super retentive. That's just an easy way to achieve that with the patient. Education. Didn't do a ton of these, but it makes sense that if you've got this edentulous space, there's a lot of bone loss, and the common workflow would be, let's do a crown and bridge case here, implants, do some bolted down crowns. But what are you going to do about the gum? All right, you're going to pink porcelain. That's a challenge, right? Making it look good, and then when you get it there, it's got to be cleansable. So conus could be an option here where we can get the flange, but yet the patient can take this thing out to clean it. Didn't do a ton of those, but we did them some. This is one of the first digital ones. So you can see the pre-op, and this guy was a mess. All these teeth are going to come out. And so we took the scans, we designed the first step, right? And so the printed or milled trians go to surgery day, all the teeth come out, and we deliver the trians. And this guy was a bigger mess than the surgeon anticipated, so decided to place, 2 or 3 of these little trailer hitch balls. These are just going to be in during healing, just to help retain and support the treatment denture. That's all. And so delivery, and so what you're going to do is just obviously healing, but also this is where we can dial in the bite. This is not his bite. We didn't get a good picture of the facial look of the bite, but the bite was off a little bit. So, we had to grind and, add a little bit to these things to get his bite dialed in. Get his midline correct. And that's what healing and treatment's about. That's why we call it prototyping, right? We make these prototypes for a reason, and that is to dial in everything to get the tooth position where it needs to be. So once that was done, right, now you can see the data that we have, right? If we've got the data, now we know where the abutments need to go and where the teeth are going to be because we've already dialed it in. And we can design our restoration and design the placement and get those abutments made. And this is the case where we milled and milled that denture out. And this dentist wanted us to pick up the housings in the lab, so we just set up on a reline jig, cut the little the gasket sleeves down a little bit, use some metal primer, adhesive to help them stick better, and there they are. They're picked up, and we went to delivery. And so, there he was before, final try-in, and then the abutment placement, and he's done. So CONUS, just like locators, that's like we can do this in 2 appointments as well. And the way we do that is the same way. We start, obviously, I want the patient to have dentures. So if they don't have dentures, then we make them some treatment dentures and, get those, all the tissues, whatever, till everything's healed up. So the implants are placed, and we're going to take those dentures and do wash impressions. And before we go out of the mouth, we're going to scan the bite. Then we're going to take those dentures out of the mouth, and we're going to scan those dentures inside and out. So now I have tissue data, I have implant placement data, and then we're going to take the cover screws off and going to put some scan bodies in. And for the CONUS, we have to use the Atlantis scan bodies, and we put those scan bodies in and scan it again. And so again, wash impression of just the cover screws, scan the bite, take the dentures out, scan the dentures, scan the wash impression, then take the cover screws out, put the scan bodies in, scan that, and then put the cover screws back on and send the patient back out with their treatment dentures. So with that data, upper left, now I have everything I need to know to make the denture. So we can get the abutments ordered, we know where to put the teeth, we know how to get everything done, so we can print or mill, complete the final dentures digitally, and then at delivery, it's a 2 appointment process. And again, I say 2 appointments. Obviously, the implant placement, the healing, and all that, some more appointments. But when we get to the point of we're ready to go, we can do it in 2, and works really well. Now, I'm going to show you these videos of this guy. This was a case we did with a doc in Georgia, and this guy was a farmer figuring stuff out, no problem, right? He understood it and was not afraid. And so when you deliver these things like you do with locators, you wonder, right? Can you get it out, right? So we tell him, put it in. We need to see you get it out 4 or 5 times. And so this first try, we explain what we did. It's very retentive, and we need you to get it out. So if you watch, right, he's tugging. He's tugging. Look at his knuckles. They're turning white. Whoop, he gets it out. Kind of startles himself and the rest of us. We said, now look, I want to explain to you the retentive element, right? So I told him a little bit about beer glasses and how they stick together. And I said, if you had a beer glass stuck together, how would you get it out, right? Well, you wiggle it a little bit. I said, okay, now take that concept to your denture. And so we made no changes, right? This is literally 10 seconds later after a quick conversation. And the second time he's taking them out, he understands. And you look, he's wiggling it, boom, drops right out. No change in retention whatsoever. But a minute ago, he had to really yank it and pull on it to make it come out. And that's the beauty, what I think of the CONUS. So 2 appointments, just like the locator. Right? So traditionally, we were doing it before in 4, 5, or 6 appointments. And now we've got it down to 2 using digital technology. And this is pretty cool. This is a validated workflow. This is a Dentsply Atlantis product, but there are other competitive systems out there, and most of them are validated now. And I'll finish real quickly with the digital fixed. This is kind of a newest trend where we're taking these not only these, domino-looking scan things. Now we have intraoral scan posts that are super accurate. Like this, this is a super accurate. It's about 50,000 microcrystals on this scan body. So it takes advantage of all the accuracy we have in our intraoral scanners today. And you can scan, like that full arch 6-unit case. You can scan that, and you can use that data to get the restoration made and avoid a verification appointment, right? It's that accurate of data. And so the lab can order the design and fabrication of the bar. It's also Atlantis product. And when the bar comes in, the lab can already have the zirconia made, and boom, just drops right into place. And you cement those 2 pieces together and you send it to the dentist for delivery. Dr. Montana, Dr. Ludlow, all have done tons of these, and they say it just blows them away how well this fits every single time. And so that's just a printed denture to the same thing, right? So it doesn't really matter. It's digital. We can make what we need to make, and we just have to glue these things together and you're ready to go. So on the clinical side, you had the patient implants placed, healing, prototyping, bite, smile, everything's good, and then scan, and then the next appointment deliver. We've cut at least 2 or 3 appointments out of an all-on-X restoration using this product. Now, this one's called Bridge Base, and this is just a quick overview of, this is the prototype. We're scanning the prototype. We're scanning the scan post, right? So we've got the teeth where we want them. So we scan those teeth. And then now we're scanning the scan post and all these scans. There's 5 main scans you have to do. And yeah, they can be challenging scans, but most digital technology makes it pretty simple. And from those scans, we can have this restoration made and it's done. And you're delivering it on the very next appointment. And I asked Dr. Montana in Chicago this year how many he had done. And he said dozens. And I said, how many have not fit in the mouth? And he said, one. I said, that's just awesome. So again, this is just one product called Bridge Base, but it really works well. Um, it's a very simple process. It can be done with full arch, but it can also be done for 3 or 4 unit bridges. So imagine a 3 unit, 4 unit screw retained bridge that all you do is put these scan bodies in, scan it, send it to the lab. The next thing you do is you get your screw retained bridge back. Pretty simple. And, so I love where we are with technology and scan bodies. So these are the 5 scans that we accomplished for the Bridge Base or the All on X digital workflow. 5 scans, and on the next appointment, we're delivering. They have some really good tools and help, but one of the things I like about National Dentex is they have a whole team of people that will also guide you through it, either on the phone or in your office. And so it's just thinking differently, guys. When we think about, all on X and digital workflow, we have all these tools that allow us to scan and design and create restorations that fit extremely well. And the data is so good that we're doing it in fewer appointments, fewer steps, fewer processing. So we're thinking differently. The top horizontal roll would be an analog way, right? Impression, models, verification jig, then a bite, then the next 2 steps. But with digital, we cut out a lot of that step and we cut a 6 appointment workflow down to 3 or 4 pretty simply. And so this is the basic workflow for one of these digitally all on X. And most every one of them have some sort of metal bar inside the restoration, and most of the restorations are zirconia overlaying that metal bar. And the steps are, again, see, this is one of Dr. Ludlow's cases, right? Obviously, the left picture is placement. That was from a plan, surgical guide. And then there's the healing, the prototype, upper denture. This patient was going to get an upper new digital denture and a lower bridge base case. So here we are after healing. Dr. Ludlow did a wash impression. So he scanned his bite. And now he's scanning the prototype in the mouth. And he always says, look, you want to get not only the prototype and the teeth, but you want to capture as much tissue data as you can as well. And when you have something fixed in the mouth like this, the scanners do a better job of capturing tissue. And so things like retromolar pad, muscle connections, all that's data that the softwares can use to help align all these scans. So it's important to capture as much data as you can. Again, not always the easiest scan, but it's certainly worth the effort. And we will get a more accurate result, because we have something hard in there. There's the treatment healing denture prototype, everything's dialed in, the bite, the teeth, where we want them now. And so wash impression. And so you take that out and obviously he scanned it with his intraoral scanner. And so we have that data now. Now we're scanning the bite. And with all this data, right, and the last bit of data is the scan bodies. We have to do 2 scans, one of the MUAs and then one with the scan bodies. So, the technology today, it used to be an issue that when you had something silver and shiny, that was a problem for intraoral scanners, but not so much anymore. Most all the new technology handles this pretty well. And so we scan that, we scan the scan posts, and this is the most critical part to really make sure that next appointment goes well, is that there's a ton of data on these scan bodies and your scanners can capture it, but you have to make sure you capture it. So as you see, as he's going here, there's some data holes on the backside. He's got to make sure you clean all that up. You really need a good, as close to 100% scan of that scan body as you can get for this to really work effectively. And you can see after a while, he got it right. And it was a good scan. And so there's all the data we need. And from that, we can order that bar. And while that bar is being made, it's 3D printed, pretty sophisticated technology, we can go ahead and make our restoration. And that restoration could be, as you see here, a printed PMMA prototype. So maybe we weren't quite sure about the bite before, so we want to do one more check. So we print this prototype. And this one, you can see the midline was off that we did. So obviously, it's nice having that prototype before we had the zirconia, so we could dial that in a little bit further. But some people don't even do that. They go straight to the zirconia. But it could be a zirconia overlay. It could be a printed denture overlay. It could be a milled PMMA overlay. We have all the options. and, to pick what and where. Dr. Ludlow, for this case, picked a printed denture overlay over the bridge base bar, and because the denture was a printed denture, and he was just like opposing like. That was the reason he picked that. So this QR code will take you to a form you fill out, and it's my handouts. And so anything that I showed in here, most everything, there'll be some information about that in that handout folder.